Hello, Dr. Diana Chapkin.
Hi, I'm Dr. Carolyn Alexander. Nice to see you guys.
Great, welcome. So today we are going to hold a webinar entitled, Do I Have PCOS? What you need to know about polycystic ovary syndrome with Dr. Carolyn Alexander and myself, Dr. Diana Chapkin. So welcome. Next slide.
Okay, I was born and raised in LA. I went to UCLA for undergrad, and a lot of my research during fellowship was on polycystic ovary syndrome as well as recurrent pregnancy loss. I really just love helping patients as Dr. Chavkin does, and it's a joy to work with such smart, kind people. And I love it here at SCRC. I've been helping patients with our embryology lab here since 2007, and I feel like it's been such a joy helping and working hard each day to think it through each case individual. And with PCOS, I think it's a very important topic because a lot of the time patients' concerns are sometimes pushed to the side or not considered important. So I think it's important that we talk about it. And so next slide.
Hi, I'm Dr. Diana Chapkin. I specialize in third-party reproduction, reciprocal IVF, minimal stimulation IVF protocol optimization. So one of my focuses in my research has been in IVF protocol optimization, specifically in women with low ovarian reserve. I focus on fertility preservation and recurrent pregnancy loss as well. I have a special place in my heart for polycystic ovary syndrome as well. I'm very much a feminist and an advocate for women's and reproductive health. And I think polycystic ovary syndrome, as Dr. Alexander had mentioned, unfortunately is sometimes pushed to the side, right? So women come in and they say, I have PCOS, I want to get pregnant, and they get pregnant and we help them and whatever it is. But sometimes it's the overall health of the woman that can kind of be pushed to the side. And I think when a woman comes in with polycystic ovary syndrome, it's really an opportunity for us to address her overall health and lifelong care, because that is really ultimately extremely important. In any case, so I'm from New York City originally. I did my undergraduate at Columbia University, did my medical school at New York University, did my training out at the University of Pennsylvania for my residency and fellowship, practiced in New York for a number of years, moved out here to LA about 10 years ago. I joined SCRC in May, and I'm so incredibly excited to be part of this amazing, amazing team. Such a wonderful team of physicians who have just a wealth of knowledge and such incredible experience. The staff here is just phenomenal. There have been people here who have been here for over 20 years. It's just really such an extremely amazing place with such a long tradition and such amazing success rates in our lab. I just couldn't be happier and prouder to be part of the team. Next slide.
Awesome. So here at SCRC, our lab started in 1999 with Dr. Mark Surrey and Dr. Dancer, and our team has grown and we've evolved to have now, I think we have 15 embryologists working on-site surgery center. We have our different locations. Our Beverly Hills Center has a full lab with a full surgery center, as well as our Santa Barbara, I call it the sister facility, where it's a equivalently amazing embryology lab and team there. We have offices, satellite offices in Pasadena, Ventura, and we used to have Burbank as well as in the South Bay too. Next slide. And our lab does a double witnessing verification system. We were one of the first places to do PGTA for a single gene mutation. We have time-lapse morphokinetics, or the embryoscope, where it looks at 1,000 data points on the embryo. And sometimes when we're differentiating between two super good-looking embryos, which one could be a little better, sometimes the embryoscope data could guide us to help us understand the little nuances that may occur when we're not visibly looking at the embryo. And so it provides more data to help guide us to get us a healthier, successful pregnancy. Next slide. So today we're going to do September's PCOS awareness. We'll talk about the diagnosis and symptoms, PCOS and fertility. We'll talk about education. What are the fertility treatment options? Meet our team, and we're always happy to answer questions. One time we answered, I think, 27 questions. So we're always happy to answer any questions if someone has anything specific. And after the consult, you're welcome to have a consult with any of the doctors, and we're looking forward to helping in any way. Next slide. Are you going, Dr. Chavkin, or is
sure,
my
sure.
part? Or is okay? I wasn't sure.
It's okay. Switch off. I'm happy to talk. So September is PCOS Awareness Month. I think it's so incredibly important that we have these dedicated months where we say, okay, we need to dedicate some time and mention, specific diseases and really bring attention and advocacy. As I mentioned, polycystic ovary syndrome is not just about infertility. It's about a woman's health and lifelong health and care. So polycystic ovary syndrome is the most common hormonal disorder in reproductive aged women. Approximately 1 in 10 women have polycystic ovary syndrome, and many women actually who come to see us for infertility don't even realize they have polycystic ovary syndrome. They come with a number of symptoms, and some of which may be infertility related, but it's kind of up to us to take a really good history and a physical exam and do what we need to do to potentially sometimes make these diagnoses. PCOS is the most common cause of irregular ovulation and menses and ovulatory infertility. So some women come in basically just saying, I hardly get a period. I'm not sure exactly what's going on. And polycystic ovary syndrome is one of the most common reasons for these irregular periods. It's defined by ovulation dysfunction and androgen excess. So, if a woman does not get a period once a month, then we're often keyed into the fact that, okay, she's not ovulating regularly. And often just the history alone of regular periods or irregular periods clues us in to whether she's ovulating regularly or not. It's often associated with impaired insulin response, insulin resistance. And so this is kind of like a tricky thing. So insulin resistance, because it's tied to polycystic ovary syndrome, often unfortunately creates a situation where women with polycystic ovary syndrome are predisposed to have issues related to metabolic syndrome, prediabetes, diabetes. And so diet and health and education are so incredibly important. The hard part about this is that women with PCOS, because of, again, related to insulin resistance, have also a harder time losing weight. And so that, again, puts them at higher risk for actually having symptoms related to polycystic ovary syndrome. So it's so incredibly important that a multidisciplinary approach is taken. And when we identify polycystic ovary syndrome, that we often refer to nutritionists and we talk about diet and health and exercise and different foods potentially that should be eaten to help with increasing insulin sensitivity. Next slide. So age factor. So this is related really to kind of any woman who's thinking about fertility. So we know that as a woman ages, her fertility will decline. And so what you see here kind of on the left-hand side are these little skinny bars. And what this shows you as, at the age of, let's say, around 22, 24, 26, the average chance of conceiving in a given month is, about 20-25%. And that holds steady for a woman as she increases in age up till around, 28, 30. But in a woman's early 30s, we start to see that decline. In that in a given month, the chance of conceiving in a given month is no longer 25%. It gets closer to maybe 20%. And then as she hits her late 30s, maybe closer to 10, 15%. And that, early 40s, mid 40s goes down significantly. This is related to a decline in egg number as well as egg quality. So as a woman ages, she loses eggs from her ovary that don't get replaced. Women don't grow eggs in their ovary over time. They lose them steadily. And also the eggs in our ovary will undergo changes, chromosomal changes, which makes it harder for eggs to fertilize. So if the egg carries with it an abnormal number of chromosomes, then it's not going to fertilize, it's not going to result in an embryo, and it's not going to result in a normal embryo. And so what that translates often into is infertility as a woman ages. On the right-hand side, we see age in years by percent of normal eggs. So this relates to the fact, again, what I mentioned, in that as women age, they have less normal, less chromosomally normal eggs. And so and as the eggs are chromosomally abnormal, as that increases in age, fertility declines as well. And so what this shows you here is at the age of 30, you have the highest percentage of normal eggs. And as you're getting older, you have less and less normal eggs in your ovary, again, relating to the infertility. Next slide. So how does PCOS affect fertility? Polycystic ovary syndrome, again, one of the most common etiologies and one of the most common presenting symptoms is anovulation or irregular menses, which clues us into the fact that there is anovulation and irregular ovulation. If a woman does not ovulate regularly, right, if she's not releasing an egg, well, then the egg and the sperm are not going to meet, and therefore infertility will occur. So if regular release of mature eggs do not occur, that's clearly an issue. Hormonal imbalances. So androgens, so male pattern hormones, things like testosterone, free testosterone, can also potentially hamper egg quality, ovulation regularity, and menstrual consistency. Insulin resistance, as we talked about, again, very key component of polycystic ovary syndrome, can lead to endocrine dysfunction and complications of a normal ovulatory process. And metabolic factors like obesity, insulin resistance can also impair reproductive function, can impair kind of the health of a developing embryo. And so whenever we're keyed into potentially a woman having PCOS, we do have to screen her and make sure that she doesn't have an elevated hemoglobin A1C, make sure there's no prediabetes or diabetes that also is tied to all of this and relates to the infertility. Pregnancy is definitely possible. And you know, I actually will say that women who present to us for infertility related to polycystic ovary syndrome is probably one of the well, I wouldn't say easy, but kind of one of the more promising groups of women who come to see us, because if you can imagine, if a woman has lots of eggs in her ovary, but she's not releasing them regularly, well, then what we often need to do as fertility physicians is to help to nurture the follicles, the eggs, and then potentially give her a medication to induce ovulation. I think we'll get to that. But the point is that if a woman has eggs, but she's just not releasing them, and we can get her to release the eggs with simple medications, we can often significantly improve her fertility and her chances of pregnancy. So we are definitely here for you. Oh, sorry, now in this picture here on the right, so you see the picture of kind of a normal ovary. So there's a number of follicles, a number of eggs that are present at any given time, which gives us kind of an idea of what the resting ovarian reserve is. What you see here on the further right-hand side is what a polycystic ovary would look like, which basically is lots of follicles, lots of eggs that are sitting there, but they don't release, and so you don't see the development of the follicle, and you don't see a corpus luteum developing, just kind of lots of follicles in an ovary. Next slide. So how is polycystic ovary syndrome diagnosed? I alluded to it a bit earlier, but essentially we say that you need 2 out of 3 criteria to make this diagnosis. So one would be clinical and or biochemical signs of hyperandrogenism. So if somebody has, let's say, male pattern hair growth, so hair potentially on their chin or face or upper arms, that would be a sign of hyperandrogenism. Male pattern balding, so kind of some baldness at the top of the head, or high levels of acne might be a sign that there's elevated androgens. We also can get blood work to confirm or to look for elevated androgens, and maybe clinically it's not apparent, meaning they don't have, the hair or the baldness or the acne, but they still may have elevated testosterone. And so we get blood tests to see if that corroborates a diagnosis of polycystic ovary syndrome, or if they meet that one criteria for polycystic ovary syndrome. The other would be irregular or lack of menses, which indicates irregular or lack of ovulation. Again, one of the most common presenting signs, at least to us, for polycystic ovary syndrome. And then polycystic appearing ovaries on ultrasound, and this is essentially what it would look like. So again, multiple follicles, lots of them, and we can see that on ultrasound. We also, though, need to make sure that there is not anything else. So we also say polycystic ovary syndrome is a diagnosis of exclusion, right? So there are other explanations for why potentially, or things linked to why a woman might have irregular periods, and we need to make sure that that's not the case. So we need to do ovarian reserve testing. We need to make sure that the AMH is good, because if a woman is, let's say, perimenopausal and has low AMH, well, that actually might be related to irregular menses. And so we need to confirm that that's not the case. We need to get prolactin and thyroid and different hormones also, just to confirm that there's not anything else to explain these other symptoms. Next slide. So what are some of the hormones involved? So high levels of male hormones, so testosterone, DHEA, 17-OHP, we need to get all these levels to kind of hone in on the diagnosis, and again, confirm that there's not something else going on. But these elevated androgens, like DHEA and testosterone and free testosterone, can lead to symptoms like acne, unwanted facial or body hair, and thinning hair. Insulin resistance, so again, reduced sensitivity to insulin, raises insulin levels, and can worsen the androgen excess, increasing blood sugar and contributing or predisposing a woman to diabetes. And potentially there's a link with progesterone deficiency. Next slide. So common PCOS symptoms, as we talked about over and over again. So irregular or absent periods, again, indicating irregular or absent ovulation, infertility or difficulty conceiving, excess facial hair, body hair, weight gain, especially around the abdomen, linked to insulin resistance, and then also high blood sugars, risk for diabetes. Also, this is also all linked to metabolic syndrome as well. So high blood pressure, elevated cholesterol, depression, anxiety, sleep issues, and in some cases, early puberty signs. Next slide. So nutrition and diet, so incredibly important. It's really crucial in managing PCOS symptoms. So thinking about foods that are low in the glycemic index. So whole grains, if you're going to eat grains, so brown rice, quinoa, legumes, fruit, vegetables, and not to say that this is easy. It's not like, okay, PCOS, go ahead and do this, right? We know that it's not so simple, and that's why I really think it's important to have, honestly, a multidisciplinary approach with the nutritionist, potentially a therapist, physicians on board, and it's about just trying your best, quite honestly. It's not about doing everything 100% all the time. Anti-inflammatory foods as much as possible, spinach, berries, fatty fish. Quite honestly, though, this diet, I actually recommend this to almost all of my patients who are going through infertility. I mean, it really is also a happy, heart healthy, body healthy diet. So it's something that I often do recommend, but very, very extremely important, specifically for women with PCOS. Next slide. Okay, and that's me.
Great. Thanks. That was so thorough and detailed. And I like hearing when you're talking. I'm like, it's so nice. It's awesome. So when we think about why, when we're trying to get pregnant, we try to tune into the medical history. If you have a history of asthma, make sure it's up to speed, that you have all the tools you need if you had an asthma exacerbation. If your thyroid's acting up, either hypothyroidism or hyperthyroidism, to work closely with a thyroid expert as well. If you have any specific family history of blood clotting disorders, it's important to tell your doctor so that we can do a deeper dive into thrombophilia panels. The physical exam is really understanding that your pap smear's up to date, that your annual physical, if you need a mammogram, if you have a family history, or if you hit the age that you need your mammogram, it's important to do the transvaginal or pelvic ultrasound to look carefully at the ovaries. As Dr. Chavkin mentioned, it made me reflect and remember a patient who thought she had PCOS, but in the ovary was a sertoli tumor, which is a pretty important thing to catch. It's a unhealthy type of a cyst that can make high testosterone and make hair develop on the chin and make patients think they have PCOS, but lo and behold, it's a ovarian cyst that's not a healthy type of a cyst that needs to be removed. Also, the adrenal gland makes 17-hydroxyprogesterone, and so that can be a issue that's called non-classical adrenal hyperplasia, or sometimes we can find simple virilizing CAH. And so it's important to tease out whether it's really polycystic ovary syndrome or something else. In addition, sometimes we'll see symptoms of Cushing's syndrome, such as striae or the pink stripes on the physical exam, a buffalo hump. Sometimes high diastolic blood pressure is a red flag for Cushing's. And so some women are told, oh, you have PCOS, that's about it. And then they're given a pamphlet. But if it's could be other things, it's good to work closely with a medical endocrinologist to look carefully at the adrenal gland, whether it's produced testosterone, total and free testosterone from the ovary as well. In addition, for diagnostic testing, we like to understand that the fallopian tubes are open, because sometimes people say, I've been trying for a year, I'm ovulating, I get a positive home ovulation predictor kit, my husband's semen analysis is normal, and then lo and behold, they may or may not have what's called tubal factor, which can impact the egg and sperm from combining, and that's important to understand. Sometimes endometriosis can impact the ability of the tube to undulate for the egg and sperm to combine, and so there can be other risk factors that we have to think about when we're trying to get pregnant with PCOS or even without PCOS. Next slide. In terms of testing, the AMH anti-Müllerian hormone is produced by the granulosa cells, which surround the eggs. I think G granulosa cells for girls, it makes estradiol, T for theca cells, testosterone, and that makes androgens. They rely on each other, but the AMH is produced by the granulosa cells around the follicle in the rim. And at a younger age 26 to 29, we hope the AMH is sort of 2 to 6. It can even be up to 8. Above 8 is a smoke signal sometimes of polycystic ovaries, but a recent article just came out trying to look at different ethnic backgrounds and whether AMH could predict polycystic ovary syndrome. And interestingly, in the article, in some ethnic backgrounds, it was 6 and above as a smoke signal for PCOS, but it's not the diagnostic tool. As Dr. Chavkin said, it's 2 out of 3 criteria as long as we rule out other factors. At age 30 to 35, we are hoping the AMH is 1.4 to 4.2. At age 36 to 39, 0.84 to 2.8. At 40 to 44, 0.42 to 1.4. And above 44, it's common that it tends to come down, but we have had pregnancies into our 40s and even into our mid 40s. And so it's not a perfect test to predict who's going to get pregnant. It's just a tool to decide, as Dr. Chavkin mentioned, which protocol is tailored to your specific age, your body mass index, whether you have PCOS, whether you have proven endometriosis, whether your ovaries have a few follicles or many follicles. So there's many different factors that determine which protocol could get the most and best success for your situation too. Next slide. Male testing is really important. There's been many cases where they'll come in to see us and they've been trying for a year, sometimes 2, and then lo and behold, the semen analysis reveals an unhealthy level, and we can jump on it, have them see urologists, optimize their lifestyles, and improve things. But we want the volume of the ejaculate to be over 2 milliliters We want the concentration, which is how many million per milliliter, to be over 20 million per milliliter. Motility is the speed, and we want them over 50% progressive or fast. The morphology is a deeper look at the shape of the sperm, the head, the midpiece, and the tail. And depending on the criteria on your test, it can be over 14% or over 5%. And studies indicate that about 25% of the time, primarily the issue with infertility is male factor, but typically majority of the time it's a combo. It's partly egg factor or age as well, and partly sperm quality. The image on the right is a picture of all the different looks of sperm. I tend to tell guys, as women, we're really focused on trying to be as healthy as we can to carry a pregnancy. But what men do for about 72 days impacts epigenetics of the blessed sperm that's going to make it into the egg. So I say, give us a few months of lots of fruits and vegetables, avoiding chips and processed foods and fried foods, trying to limit alcohol. If you're overweight, trying to get to your ideal body mass index, and really trying to avoid artificial sweeteners, because sometimes Splenda aspartame may impact at a molecular level at the sperm. And also, if you're on medications like amlodipine or rheumatoid arthritis medications, talk to your doctor, because if you're trying to get pregnant and as a male trying to see that your medications aren't having an impact on the sperm's ability to fertilize the egg or get a healthy embryo for you guys. Next slide. All infertility treatment options. So we think of in vitro fertilization, embryo transfer, blastocyst transfer, pre-implantation genetic diagnosis, sperm retrieval. So some patients have an absence of the vas deferens, so their ejaculate comes out, but there's actually no sperm there. The sperm's still sitting in the epididymis, and we have to retrieve the sperm. ICSI is where we literally pick the best appearing sperm with a high power microscope and place it into the egg. It's called intracytoplasmic sperm injection. Donor sperm program's really important. It's either a directed donor, which could be someone you know, or an anonymous sperm donor. Egg donation. In some patients, we have, it's called premature ovarian insufficiency or age-related changes to our egg quality and supply. And so we have a heart-to-heart and talk about getting an egg donor, which can be fresh eggs or frozen eggs. It's sort of a different statistical option, and we talk about the different options. And our egg donor program is run by Suzanne Bangus, who's wonderful, and she really helps us find healthy donors for our patients. We look at their age, their own egg supply, whether they've been a donor before, and their health and lifestyle and family history and genetics. Semen and embryo cryopreservations, or sperm and embryo cryopreservation. A lot of men now, by the time they're 45 or towards 50, and they're not ready to start a family, they think about protecting their future, because after age 50, there's an uptick in autosomal dominant disorders as well as epigenetic changes, and sometimes a slight increased risk of autism. And so some men are being proactive and thinking to freeze sperm. Sometimes if people are starting certain medications, they'll think to freeze sperm. Embryo cryopreservation is to freeze embryos, maybe then try naturally, which some people do, and save those embryos for future children. And you can carry an embryo till you're into your 50s, as long as you're healthy and avoiding toxins and making sure all your checkups are up to speed. Assisted hatching, we're asked about this a lot. So as we hit age 40, the zona pellucida, which is the protein layer around the egg, gets firm. And sometimes the embryologists actually literally have to make a little hatching point so that as the embryo develops, it can hatch. It almost looks like the infinity sign. I might have one of them up on the wall here, but that hatched embryo has a better chance to latch on and stick inside the uterus for an embryo transfer. So for PCOS specifically, we try our best to think through the protocol and to really do our due diligence to avoid hyperstimulation syndrome. In addition, we have Leah Eridat. She works on the first floor as our infertility acupuncturist. She's part of our team, but we work closely with all the acupuncturists who are really lovely in the area, as well as near your work or at your near your home, so that it's convenient for you. When I was trying as an older parent, I found acupuncture really helped me in my process. I feel like it was sort of part of the magic to help me conceive. Intrauterine insemination is called IUI. So sometimes if the sperm motility is suboptimal, or if we're worried that the sperm isn't really getting through the cervix, if we've had a LEEP procedure or a cold knife cone, sometimes placing the sperm to the top of the uterus and gently placing it in is called IUI, and it gets a slightly higher chance than natural conception, but not as high of an opportunity as the in vitro fertilization, which we're going to talk a little more about. Next slide. So the egg retrieval timeline. So a lot of people say, I'm here, I want to think about freezing my eggs. I'm ready to think about IVF and what's involved. So as Dr. Chavkin mentioned, lifestyle, preparation, vitamins, making sure you're staying fit, eating right. As you prepare your body to do the procedure and the 2 weeks of injections. The injections have been around since 1970. They're called follicle stimulating hormone, luteinizing hormone, as well as sometimes we use human growth hormone. We have to use a medicine to block the body from ovulating. And so there's a couple with different ways to approach that. And so your doctor will tailor your treatment plan. On average, patients take 10 to 14 days of the shots to recruit the follicles to grow. There's about 5 to 6 ultrasounds to check that the follicles are growing in a symmetric fashion. We want to make sure your estrogen's not going too high, isn't too low, to monitor closely how your body's responding to the protocol. And then there's the most important shot, which is called the trigger shot, that helps loosen the egg from the sidewall. It helps the egg mature. And so when the needle goes in for the 20-minute egg procedure, it's under gentle sedation. We carefully get the egg out. It's smaller than a grain of salt. And the egg is then cleaned off, and the embryology team either flash freezes it with vitrification, or they use a high power microscope and pick the best sperm to place the sperm in the egg, or they can dip the egg with about 20,000 sperm as well as another option to fertilize that egg. Next step. So with the egg retrieval, this is a depiction on the left of the transvaginal ultrasound with the thin needle to carefully go into the ovary. As each follicle is drained, it'll kind of shrink down, and we wait to hear that we got that egg, and then we go to the next follicle. So it's kind of a process of carefully getting the eggs. There is always, heaven forbid, a risk of pain, bleeding, or infection. It's important to talk to your doctor if you have any pain that's out of the ordinary. Typically, most patients don't have dramatic bleeding, but there is always a small risk, especially if you've ever had dental work and had a lot of bleeding. Always let your doctor know, or your first period was unusually heavy. There are times where people might have von Willebrand's disorder. And so it's good to talk out any prior surgeries you've had with your doctor. Next slide. This is a picture of ICSI, or intracytoplasmic sperm injection. So we go perpendicular to the polar body, and the sperm is placed directly in. A little bit of the cytoplasm is drawn back, and then the sperm is placed inside. It's kind of beautiful to see. Next slide. This is an image of the embryoscope. So the embryo is developing from 2 cells to 4 cells to 8 cells to 16 to 32, up to the 100 cells or so for the hatching blastocyst. And then you can actually see that the inner cell mass is formed, then the blastocele, which is below, and the trophectoderm, which is on the outer rim. The embryoscope data is helpful in certain situations, and it does provide information. Next slide. This is another image of how we're going to take the fused cells off the perimeter of the embryo. So the infinity sign, the outpouch, is the actual trophectoderm outpouching. And then the team is taking a few cells from the perimeter there. And the inner cell mass is far from there. So we're very careful with this process. And then the embryo can be flash frozen with vitrification. And those few cells go to the genetics facility to amplify the DNA to look that there's 2 chromosomes for each chromosome and to detect what's called aneuploidy. It also looks at mosaicism. We here are allowed to transfer low-level mosaics of certain chromosomes, and we've had many pregnancies from them. And so we're looking carefully at specific genes in some patients who carry sickle cell trait, where both partners carry that. Sometimes one partner carries BRCA1 and we want to check its autosomal dominant. So we want to check the embryo for that specific issue, and we hope to avoid it for the next generation. Next slide. Frozen embryo transfers, there's sort of 2 categories of how we approach it. One is we're naturally modified, where you ovulate and the receptors for the embryo to kind of Velcro in are upregulated by your own body's ovulatory function. And then the embryo is placed in a week after ovulation or so. The other way is some patients are not ovulating and we don't have the luxury to think to try a natural try. So we have to thicken the lining. It's like grass. We're trying to make the landing pad for the embryo be as thick and healthy as possible. And so we provide estrogen, whether it's oral tablets, transdermal, intramuscular, or vaginal, to kind of optimize the way that the uterus is going to thicken the lining. Once the lining's at a certain thickness, the estrogen's at a certain target, we want to make sure the progesterone's low when we start progesterone, and then we start the progesterone as either intramuscular progesterone in sesame oil or olive oil or ethyl oleate, or we can give oral and vaginal prometrium to uptick the receptors so that the embryo can bind on and link in. And so embryo transfer day is an important day. I always tell patients, have a really good breakfast, bring the Valium with you so you can relax your pelvic muscles for the doctor, and try to rest for a few days and listen to your doctor. Some doctors have specific guidelines that they recommend. And then typically we check the pregnancy test a couple weeks after the embryo goes inside and we hope and pray for the embryo to attach. Everyone always gets excited for the embryo transfer day, and it's a big step in the process. You can save your extra embryos for future pregnancies as well. Next slide. So we're happy to talk about the free AMH testing. A lot of people want to understand their body and understand what's going on with their hormones. I think even for myself, looking back when in my journey, I think it's important to really feel comfortable to ask your physician or your caregiver questions, and bring your questions to each visit and really think about your questions so that you feel like you got everything answered. Any concerns, everyone's open to hearing and tuning in to understand what can we do to get things better. I'm happy to answer any questions, and Dr. Chavkin may chime in.
Awesome, that was great. Thank you, Carolyn. Yes, here are some more promotions. Here's our amazing team, Dr. Mark Suri, Dr. Hal Tanzer, Dr. Alexander, myself, Dr. Maxwell in Santa Barbara, and then Miriam, our amazing nurse practitioner. So yeah, please ask some questions. Happy to speak with you some more.
I think one other thing for the embryo transfer part is some patients need a couple months to get their body at their best weight, their best cardiovascular fitness, make sure they're on folic acid or prenatal vitamins to make sure to prevent spina bifida. There's a lot of preparation. Some patients are like, I want my embryo transfer right away, but we have to prepare and make sure all the tests are in order to optimize the success of the process too.
Yeah, that's such a great point. And I think also, specifically related to polycystic ovary syndrome, right? So, we may have women who did an IVF cycle, they have embryos and they have polycystic ovary syndrome. We absolutely, prior to an embryo transfer, need to make sure their glycemic, their glucose is completely controlled. Sometimes we'll connect with the maternal fetal medicine, a high-risk OB doctor, and have them get screened. Sometimes there are recommendations that we need, especially if they have an actual diagnosis of diabetes. And so that absolutely needs to get in order before an embryo transfer is done. Any questions for us? And if there are none, that's okay too. We're more than happy for you to kind of mull this over and reach out to us at a later point in time. We're happy to speak with you in person. We do tons of virtual consultations as well, by phone, by video. We're just happy to meet you and to connect, and hope we answered some questions today.
Wonderful. Great. Great to see everyone, and take good care. Thanks, Dr. Chavkin.
Thank you, Dr. Alexander.
See you down the hall. Cheers. Bye.
Bye.